Good morning. Now, good morning, Mr. McLennan.
Good morning, my Lord.
We are ready to begin with Miss Critchley.
That's right, Julie Critchley.
Good morning, Miss Critchley. Now, as you understand, you're about to be asked questions by Mr. McLennan, who's sitting opposite you. But first, I understand you're agreeable to affirm.
That's correct.
Sitting where you are, can you repeat these words after me? I solemnly, sincerely and truly
I solemnly, sincerely and truly
declare and affirm
declare and affirm
that I will tell the truth,
that I will tell the truth,
the whole truth,
and
nothing but the truth.
and nothing but the truth.
Thank you, Ms. Critchley. Now, the plan is that we will sit, I don't know how long your evidence will take, but we will sit we'll sit between 10 and 1. We take a lunch break at 1, but we usually break at about 11:30 for coffee. However, if for any reason at all you want to take a break at any other time, just give me an indication and we'll take a break.
Thank you.
The other thing I would say is that quite a big space to fill. You've got the assistance of the microphones, and it shouldn't be necessary to sort of lean into them. They should be able to pick up what you have to say. But even with the microphones, it's advisable to speak a little more slowly and a little louder than you would in conversation. Appreciate it's not always easy just to remember that, but if I could ask you to try, I'd be very grateful. Now, Mr. McLennan.
Thank you, my Lord. Good morning.
Good morning.
Could I ask you please just to confirm your name?
Yes, it's Julie Critchley.
And you have, I think, provided a witness statement to the inquiry.
I have.
Could we have up on screen, please, Witness Statement Bundle Volume 1 at page 237? And is that your statement that we see up on screen?
It is.
And does that statement set out fully and truthfully your evidence on the matters that it addresses?
It does.
And is there anything in it that you think needs to be changed or corrected?
No.
As your statement tells us, you are the Director of NHS Scotland Assure, and have been since September 2021.
That's right.
Can I just check, is it the Director or are there other Directors of Assure?
No, it's the Director. I'm the only one.
And in terms of reporting lines, do you report into Mary Morgan, the Chief Executive of NHS Assure? Of NHS NSS?
I do.
And Thomas Roger, who's giving evidence later today, the Head of Engineering, does his reporting line come into you?
It does, yes, via his Associate Director Ian Storer.
Okay. Now, you set out your qualifications and expertise in your statement, and it may be helpful just to clarify at the outset that your background is not in construction or engineering.
No, it isn't.
Your statement says that you began as a podiatrist in 1992, but that much of your career since then has been spent in the management and administration of healthcare services. Is that right?
That's correct, yes.
You refer in your statement to having worked predominantly on large-scale integration agendas, change management, and the equalisation of service delivery. Could you just explain for us what those things mean?
Yes. So, integration. So I come from a community care background, so providing care out into the community. However, I then moved into a mental health trust and integrated mental health services with community physical health services. And that was an integration role. I then went on from there to work in the acute sector and to bring community services into an acute trust in NHS England. And finally, just before I came up to Scotland, I worked for an NHS acute trust on a mandated transfer of 5 hospitals into that acute trust.
Okay, so in sort of very broad and general terms, is your experience in merging services or rearranging services to be delivered in a different way, that kind of thing?
Yeah. to get the best value for money and the best care that we can.
Okay. And you say in your statement that you're now the executive management lead for the healthcare built environment in NHS Scotland and are responsible for the strategic direction and operational delivery. Again, could you just expand a little bit on what that means?
So when I came into NSS as Director of NHS Scotland Assure, NHS Scotland Assure had only just started delivering services. Part of my role has been to look at the governance behind that and the strategic direction for that service in conjunction with Scottish Government. Okay,
so given your background and expertise, are we right to infer that the skills you bring to bear on this role are about how to organise and deliver Assure services rather than on the technical content of them?
Yes.
Now, you also explain in your statement that NHS Scotland Assure was formed by merging two existing divisions of NSS, being HFS, or Health Facilities Scotland, and RHI, the Antimicrobial Resistance and Healthcare Associated Infection Division. And you say that Assure does everything those divisions did before, but with additional services.
That's right.
So what are the additional services that are provided over and above what those divisions delivered previously?
So there's a number of additional services. So there's the assurance service, which contains the KSAR type of service delivery. There is the research intelligence service that provides research and intelligence around guidance and how we should deliver services. There is the addition to infection prevention control of the assurance service. So that's an add-on to that, what that service used to provide. We also have a response service that we deliver for the health boards. We have an area of workforce where we're looking at how we can develop the workforce in the healthcare build environment, and we work very closely with NHS Education Scotland around that.
Okay, and you mentioned there a response service for health boards. You just explain what that service is.
So the response service is if a health board has an issue with anything to do with the healthcare build environment, they can contact NHS Scotland Assure for support in how to either reduce the risk or mitigate the risk in that area, or for advice on how they need to go forward to correct whatever has gone wrong. For instance, if there's a flood and a ceiling's come down and it's affected the electrical, then one of our electrical engineers would be involved in that, as would one of our IPC nurses from an infection prevention control perspective.
And would that service also cover things like if there was a query about what the guidance said or what it meant or that kind of thing?
Yes.
If we could go please to Bundle 13, Volume 4 at page 424. This is a document taken or which has been supplied in relation to the services of NHS Assure. And you'll see there, if we just scroll up a little bit, please, so we can see all of the bullet points at the bottom. You see the heading there, what will Assure do? And it says NHS Scotland Assure will consider all types of risk as they relate to the built environment. And then it goes on to say NHS Scotland Assure will not, and then there's a list of bullets. And these are the things that NHS Scotland Assure won't do are address or seek to change legal responsibilities of NHS boards or primary legislation, or create a central building division, as NHS boards need to remain accountable for their projects and current estate, address non-NHS healthcare environments, such as private dental practices, or develop an inspection function. And so are those the limits within which Assure is operating? It's not going to do any of those things.
Currently, they're not within our target operating model or our strategic direction, so I would say, no, we wouldn't be doing any of those things.
Yeah. Now, in terms of staffing of Assure, you say in your statement that Assure has about 300 staff,
That's correct.
and that many of those are highly skilled and experienced people. The first category that you refer to is clinically qualified staff, and at least at the time you prepared your statement, there were about 60 of those.
Yes.
Does that figure remain about correct?
That remains about correct, and that consists of infection prevention control nurses, our nurse consultants, and our healthcare scientists, of which we have a large number.
Okay. And are microbiologists included in that?
They are, yes.
Yeah. And in broad overview, what kind of work are these people doing in Assure?
So there's a number of different roles. So the infection prevention control nurses are involved in the assurance aspect, KSARs and NDAPs. They're also involved in high scribe. They're also involved in reactive type of work. And they have 6 programmes of work that are agreed with the Chief Nursing Officer's department, on which we respond on an annual basis. So there are lots of different areas that the infection prevention control nurses, microbiologists and healthcare scientists work in. But the healthcare scientists also support the production of research, which in turn supports the production of guidance.
Okay. And by guidance, are we including things such as the SHTM series of guidance?
Yes.
Yep. And you mentioned there that there were categories of work that came, I think what you said was from an annual note or requirement from the Chief Nurses Directorate. Mm-hmm. So is that something which will vary from year to year depending on the policy priorities?
It can do. However, it tends to have a core number of deliverables within that service.
Okay. So that's the clinical experts. And you also say that Assure has a team of technical experts. Mm-hmm. And again, at the time of your statement, there were about 115 of those. Again, does that number seem still to be about right?
It does. And again, they're split across a number of different professions, from engineers to surveyors to architects to FM specialists. We have a large authorising engineers, decontamination specialists. We have a large number of technically qualified staff.
Okay. And again, in broad overview, what kind of work are these technical experts doing?
So that depends on where they sit within the organisation. So we have a number of different areas where we have, so we have our property capital planning, which is involved in the NDAP type of services, so design. We have a sustainability team that are a national team that support the health boards in achieving or working towards net zero aims. We have a number of chartered surveyors who have been, you'll probably recognise from this year, the RAC. Mm-hmm. So they have led on the RAC surveys across the whole of the healthcare estate.
By RAC, you mean this is the issue with reinforced
concrete?
Yeah,
yes.
Thank you.
Mm-hmm. So we have a number of staff who've been involved in that. We also have an equipping service that supports the health boards in equipping delivery. So if somewhere has had a new theatre suite, we would support them in the type of equipment that they may require in that suite to deliver services.
Okay, and in terms of the allocation of technical experts across these different work areas, are those sort of watertight areas, or are there people working in more than one of these divisions at a time?
One of the things that I've looked at since I came into NHS Scotland Assure is an internal integration programme. So how we can support one another by working as a multidisciplinary team. So that's not that the technical experts would work out with their sphere of technical competency, but that they could complement one another by working together.
Okay, and is that something which remains at the stage of an idea to be worked upon, or has that been implemented to any extent?
We're starting to think about implementation now, so we have done some of the primary work around what areas we could consolidate some of our skills in and how that would work in reality in response to an ask from a health board.
Okay. I mean, one of the things we may come on to later is the matter of recruitment. Mm-hmm. And I think in your statement you say that it can be difficult to recruit people with the right sort of technical skills.
Yes.
And is this way of organising the workforce going to help address that difficulty to any extent?
I think what it does is we're looking at a commissioning process. So if a board has, or Scottish Government have an ask of NHS Scotland Assure, we would put that through a commissioning process to ensure that it gets to the right area. So anecdotally, HFS may have had a number of identical requests into, say, property capital planning, engineering, even RHI may have had the same request from the same board. When you work in isolation, all three areas could be working on the same request. So what we've done is we've developed a commissioning process where the ask will come in centrally and we will then allocate who needs to respond to that.
Okay, so is that a way of avoiding duplication of work?
Yes.
And making internal processes a bit more efficient?
That's right, and ensuring that we've got the right multidisciplinary team who respond to that ask.
Yeah, okay. You also say, just to complete the complement of staff in Assure, about 120 people in facilities management.
That's right.
What do these people do at Assure?
So facilities management, as any other health board does, we have an estate of our own, and the facilities management team look after that estate. They consist of our so they will look after the estate, they will be our catering staff, they will be our reception staff, they will be our domestic staff. So there are a number of staff that perform functions like that, but there's also the facilities management function that looks after our estate itself.
Okay, and when I saw this category of people, I wondered whether you had people who are experts, if you like, in the field of facilities management who are providing that kind of support and advice to health boards.
Yes.
Are these people also in the facilities management?
Yes, they
team?
are. Yeah. So we're looking currently at a whole system plan, which we will support other areas on as well.
Okay, and just in very broad terms, of that 120, how many are effectively servicing the needs of Assure itself, and how many of them are these experts who can provide facilities management support to the boards?
We also provide that facilities management support to boards as well. So we provide some of the boards with staff who will perform those functions in the board. So I think it's quite difficult to categorise them in that way. Mm-hmm. I would say probably we have an estates team that sits within facilities management that looks after our estate, and then we have a facilities management team who are multi-skilled to perform any of the other tasks that we might require, from cleaning to domestic work too.
All right. And how do these staff numbers, and really I'm most interested in the clinical team and the technical expert team. Mm-hmm. How do these staff numbers compare with the numbers that were in the predecessor departments, HFS and RHI?
So HFS has gone from a department of about 2 to 3 engineers to we currently have 16 engineers, an associate director and a head of engineering. But it has taken us quite a while to develop that staffing cohort because of the particular needs.
Did you say 60?
16.
16.
16.
Yes.
I'd love to have 60.
Yeah, I can see that.
And RHI, there has been a bit of a circular economy on that one. So although we have had a small number of additional posts within infection prevention control nurses, we have actually equally lost a number of our infection prevention control senior nurses and nurse consultants out into the wider NHS as well. So I think that we have taken 6 or 7 from NHS Scotland as a whole. However, our hybrid working has supported that, because previously when we were in the office all of the time, we tended to take people from the central belt because travel was an issue. Now we hybrid work, we can take people from a wider, so that's diluted that somewhat. However, On the same token, we have lost 6 of our nurses out to the wider NHS as well.
Okay. I mean, other witnesses have spoken about the shortfall in numbers of infection control specialists to meet the demand.
Yeah.
But did I understand you saying that flexible working methods are helping you address that shortfall, at least to some extent?
They are, yes. And I think that, we have had more interest from further afield than we traditionally would have had because of the hybrid working.
Okay. And by further afield, how far afield are we talking?
Well, we have had somebody who works in Highland, who still lives in that locality, Ayrshire and Arran and Lanarkshire, whereas historically we would have taken perhaps from NHS Lothian or Glasgow.
Okay, and I should actually have asked, where are your premises physically?
So physically, we have a mixed model. So a lot of our nurses are hybrid working, and as long as they are willing to travel to the boards that they are supporting through whatever process, then I really don't mind where they are located.
Mm-hmm. Okay. But your office space, I presume there is an office, an Assure office somewhere.
There is. There's two headquarters, one in Gyle Square in Edinburgh and one at Delta House in Glasgow. But again, we have other estate, such as our warehouses at Coddington and Candleside. We have some buildings up in Aberdeen. So we do have an estate that is scattered across.
Mm-hmm. And you referred to recruiting some infection control people from boards, and then the reverse process where you've lost some of your people to boards. I mean, you might not put it quite in this way, but is there an element of competition between the boards and Assure for these skills?
Potentially there is, but it's not the only area within the NHS where there is a shortage of skills.
Yeah. Okay. If you could go please to bundle 9, page 54. This is partway through a document which you may have seen before. It was the target operating model for what became NHS Assure. Mm-hmm. And this is a slide which is estimating or setting out estimates of the costs. So I just check I've got the right page. Yes. So we see on this page, down the left-hand column, an estimate of costs of £6.3 million, mm-hmm. and then a revised cost of £4.2 million. And I think these were an estimate of the first year costs for setting up and operating Assure. What does it cost to run Assure services?
So the estimate for the last financial year is nearer the 6.3 million now. I can't comment on the year 2021 because I think that we were in shadow format. Yeah. I wasn't here then. I didn't arrive until September 2021. Yeah. So I think that services were not fully functioning then.
Okay. So if we go on to the next page, which was an estimate of the operating costs, and I take your point that this is prior to your arrival. Mm-hmm. The estimate at that time of the annual costs was about £6 million, and does that just a little bit more than that is what it currently costs to run Assure?
Round about 6, yeah, just a little bit more. Okay,
and how does that compare? If you know, you may not know if it predates your time, but how does that compare to what was previously the cost of running RHI and HFS?
I'm really sorry, I don't know that.
Okay.
But I think that this is the cost just for the additional service delivery. This doesn't include the HFS services that are still provided.
Ah, okay. Well, that's helpful to know. So thank you for that.
Sorry, I didn't catch that. The figure does not include did you say HFS?
And our high existing service provision. Right. So this is just for the additional bolt-on of NHS assurance services.
Thank you.
And in terms of the key stage assurance reviews, the KSARs, what's the size of the workforce at Assure that's devoted to those?
So each KSAR is different, and as you know, we have the tube map that describes the programme of KSAR delivery across the lifetime of a build. Depending on where we are on the stage of the KSAR will depend on what the multidisciplinary team is required to perform that KSAR. So each KSAR will have a multidisciplinary team that will always have infection prevention control. It will always have engineering. It will usually have an element of fire. It may have an element of property capital planning, as in design, architecture. And it may have facilities management, depending on what the requirement for that build is as well.
Okay, and this may be a how long is a piece of string sort of question, but can you give us an indication of the range in size of a KSAR team from a small team for a simple project up to a big team for a complicated one?
So if we have a complicated project, then we may well bring in other members of the teams to support that project. So you could go from a core team of 5 or 6 to somewhere where perhaps potentially nearly all of the engineers may be involved, or a number of the IPC nurses may be involved. So it could be 2 or 3 times that amount of staff, depending on the size of the KSAR and the function of the building as well.
Okay, so I mean, what kind of thing would be at the complicated end? For example, the construction of an acute hospital, or
a very large build that will have multiple uses.
Yeah. And is there a pattern to the size of team that's devoted to the different KSARs? I mean, we'll come on to the tube map in a moment.
Not particularly. It's just what is required for that build programme.
Okay.
So we will resource however we need to. And whilst we were in recruitment phase over the early inception of NHS Scotland Assure, we may have commissioned out those KSAR processes if we didn't have enough staff.
And by commissioned out, you mean, just expand on what that means?
Then we would have commissioned an engineering firm to provide some of that service for us.
Okay. I mean, is that something that happens on an ongoing basis, or does Assure now have enough staff to meet the needs of the KSAR programme?
As we have built our numbers of staff, that requirement has become less. So we have a current totality of 7 builds with an expectation of those 7 builds requiring 22 KSARs. We think we may be able to do that in-house.
Okay. I mean, what you may not have the exact figures, but just give us a rough idea. What proportion of the KSARs to date have been done by external consultants, and to what extent have they been done in-house? So
even if they are externally commissioned, we will always have one of our engineers who is part of that process. So they will never solely be done externally. So we will always have an engineer who is part of that process. So even though some elements of it may be commissioned out, we will always have an internal view of that as well.
Yes. And approximately how many of these KSARs are being supported by external teams?
So we've done to date 40 KSARs. I couldn't say in all honesty how many of those have been supported externally, but I know that the number is reducing. Mm-hmm.
I mean, if you've done 40, do you even a rough, are we talking half of them? Are we talking the majority, the minority?
I don't know really.
Okay. Now, two other services that Assure provides, I'd just be interested in the allocation of workforce to these. The first, the production or revision of the guidance. How many people are working on that from time to time?
So guidance, we have a number of healthcare scientists who are involved in guidance. So we have, I think it's about 35 healthcare scientists who are involved in all aspects of research, some of which will translate into guidance. So we have a full team who look at 33.8 healthcare scientists within infection prevention control, and then a number within our research departments as well.
Okay, and are they doing this on a full-time basis, or do they have other tasks that they perform too?
They do have other tasks that they perform as well. So they will be involved in the type of information that we may publish. For example, the COVID, when we're in the pandemic, we provided information on a weekly basis about the number of COVID cases, both in hospital and out with.
Okay, and are they involved in the KSARs at all, the healthcare scientists?
No, beyond the research element or literature reviews if we require that.
Okay, so if a bit of research or literature review is needed in support of a KSAR, they might be brought in for that purpose?
Yeah, potentially.
Yeah. Okay, and the other service is the handling of queries from health boards for advice and so on. What's the workforce allocation to that?
Again, that links into the commissioning process that we talked about a little bit earlier. So that will depend on what the commission is. So when we get an ask from a health board, we will then look at that ask and we will allocate that to the right department so that the ask is resourced in the correct way. I think that we've had, through that new service, we've had almost 50 commissions now. And I do know that 61% of those have gone to engineering. The rest of them have been spread across property capital planning, IPC, FM services, decontamination, that sort of thing.
Okay. Now, it sounds from you used the term commissions. It sounds from that you view this as a sort of, each query being a sort of formal task to be considered and then responded to. This may have been my mistake, but what I had envisaged was a health board picking up the phone and saying, "Oh, can you clarify this for us?" Is each of those regarded as a commission, or are those sort of ad hoc, informal queries?
Not
over
necessarily.
And above?
If there is just a telephone call to, then that may not make it to a commission, because if we can solve it there and then, we will.
Yes.
But actually, if it requires a dedicated amount of work, then we have an amount of time that is allocated in the work planning for all of my services for reactive commissioned work.
Okay. So in addition to the sort of query I had in mind, there are also ones that are more difficult to answer or more substantial pieces of work for Assure.
Mm-hmm. So some of them may require a piece of research to be done, or may require a significant literature review to be done before we can come back to the board.
Yeah, okay. If we could just have paragraph 44 of your statement up on screen, please. That's Witness Statement Bundle 1 at page 250. And I'm just going to read what you say at paragraph 44. You say, the fact that RHI now sits within NHS Scotland Assure is an enormous advantage for the health boards in terms of advocating the clinical delivery requirements of the healthcare built environment to all parties involved. Can you just expand on that point that you make there and explain what you mean?
So I think that being clinical myself, I think that the earlier that we get clinicians involved in a healthcare build programme, the better. So actually, you will need to link in with your clinical strategy, because that clearly articulates what you're going to utilise the space for. If we have a clear understanding of that right from the start, then we can think about risk mitigation straight away. If we don't have an idea of how that space is going to be utilised, and we don't understand that from the clinicians who are going to be delivering services in that space, then we may not design the right type of space.
Okay, and so one can understand, we'll maybe come to this later, that in a particular health board, which is going to be building a new building, that they'll need to get their clinical people involved early and speaking to the project team. But in the particular context of your organisation, Assure, what do you see as the benefits of having both the clinicians and the technical people working under one roof?
Well, because providing healthcare within a healthcare environment is a complex thing, I truly believe that we cannot just have a technical solution to that. We absolutely need to have a clinical voice in that right from the start of the process. I think that way we are much more able to understand the aspirations of the space from the healthcare provision and the board, and also it enables us then for our clinicians to speak to the clinical staff who are going to be delivering the services, as well as the IPC staff who are going to be involved in the build as well. So I think it's key.
Okay. So is there an element of Assure having people who can speak the same language as the people at the board who are developing the building?
Absolutely.
Okay, if we can look an overview at the KSAR process. Now, I really just want to deal with this at the overview level because we've got Mr. Roger coming in to talk about it in a bit more detail. Just to put it in context, if we can first of all look at why it matters, if we can go please to bundle 9, page 70. So this, as you can see up on the screen, is a letter from the Health Finance Directorate of the Scottish Government, DL 2021-14 of the 27th of May 2021. And if we just scroll down to the bottom of the letter, so this is a letter going out to all of the health boards, and what they're told is that from June 2021, all NHS board projects that require review and approval from the NHS Capital Investment Group, the CIG, will need to engage with NHS Scotland Assure to undertake key stage assurance reviews. Approval from the CIG will only follow once the KSAR has been satisfactorily completed. The KSARs have been designed to provide assurance to the Scottish Government that guidance has been followed. The Scottish Government may also commission Assure to undertake reviews on other healthcare built environment projects. This does not change accountability for the projects. NHS boards remain accountable for their delivery. NHS Scotland Assure will be accountable for the services it provides that support delivery of the project. So we see there that the CIG approval now requires satisfactory completion of the KSARs conducted by Assure. And do we also see there that it's the purpose of the KSARs to provide assurance to the Scottish Government?
Yes.
But that the accountability for the projects themselves remains with the health board?
Yes.
Can you just explain from your point of view what accountability is borne by NHS Scotland Assure?
I think that our accountability cannot be the same as that of the health boards because we are not then going to deliver services within those build environments. So I think that we are responsible for the advice that we give and the support that we give to the health boards, but they will remain accountable and responsible for delivery in those areas.
Okay. And if we go over, please, to page 71. Just the second paragraph on that page, what the letter says is that which I think we can take to be Assure will undertake a leadership role supporting NHS boards while they deliver oversight for the design, construction and maintenance of major infrastructure developments within the NHS. Now, this at first sight appears a little bit confusing because Assure is said to take the leadership role but also to support the health boards, and it's the health boards that are delivering the oversight. Just from your perspective as the director of Assure, who's providing the leadership and who's providing the oversight?
I would say that we collectively have leadership, but the oversight would be provided by NHS Scotland Assure in line with the KSAR process.
Okay.
However, most health boards do have a governance structure for major projects, and some of the oversight will come through that as well.
Okay, so there's an element of governance and oversight within the boards themselves, but in relation to the services that it provides, Assure has oversight of the projects to that extent.
Yes.
I mean, the inquiry has heard some evidence that there is, at least within health boards, some uncertainty about the division of responsibility between, or the division of accountability between health boards and Assure. If we go to the witness statement of Tracy Gillis, who's the Executive Medical Director of NHS Lothian, which is witness statement bundle 1, page 524. And it's paragraph 24, which just straddles this page and the next. And what she says is that she's familiar with Assure, and she says, I've listened to presentations from NHS Scotland Assure about their purpose and function. I've raised questions to ask that increased clarity is brought to the distribution of accountability between individual boards and NHS Scotland Assure for any future situations where the suitability or otherwise of a building is subject to review and challenge. That clarity should cover the corporate governance responsibilities of the Territorial Board and NHS Scotland's Assure's role as part of NSS. Now, is that a concern that you recognise? And if so, is there anything that's going to be done to clarify that accountability issue?
I think that we had some clarity with the DL that was issued in February 2023 from Alan Morrison, which actually states that a commissioning or handover KSAR has to have a supported status from NHS Scotland Assure before it will be permitted to open to the public and patients.
Yes, okay. And in what way do you see that as clarifying the division of accountability between Assure on the one hand and the boards on the other?
I think that will give some assurance to the board itself that they have been compliant in the way that they should be around their healthcare build, but also to SG that the board has been compliant and that actually that has been tested out through the KSAR process. Okay,
so we can see that the origins of Assure were focused on assurance to the government that the standards are going to be met and so on. But do you see this evolving into a situation where Assure's involvement is also providing assurance to the boards themselves?
Yes. And I think that a number of KSARs that we have completed, particularly for the national treatment centres that opened, that has proved to be the case. So the KSAR process has been a good process for the boards to go through, for them to understand that they have assurance that they have built their building to the best standards that they possibly could.
Okay. And is it also something that the public at large, the users of the facilities, can take assurance from?
I think that the KSAR process is a very technical process that ensures that compliance is part and parcel of that process at a number of different points throughout the build. So from the design, I mean, as you know, NHS Scotland Assure has only been in place since 2021. We have yet to follow an entire programme for a build through from initial assessment to handover and occupation, because obviously, of necessity, they take quite a long time. to go through. However, those boards that have been through more than one KSAR have said that that process brings them assurance for their governance processes that they are doing the right thing.
Yes. And just returning to the perspective of the public on this, if the public are aware that a hospital has come through a handover KSAR and that it's been supported by Assure, can they place confidence in that as a demonstration that the hospital is going to be safe for them to use?
I think it is a mechanism by which they can take some assurance, yes.
Just in the context of how other people see Assure, I'm going to read to you an answer which was given by one of the witnesses to the inquiry. This was Lindsay Guthrie, who is the lead IPC nurse at NHS Lothian when she was in, I think, last week, 1st of March. And this is what she had to say about it. And I'd just be interested in your response to this. So she says, and for anybody who wants the reference, it's page 155 of the transcript for the 1st of March. She says, so if I'm honest, I'm still not entirely sure I fully understand the role of NHS Assure in relation to some of these projects. It feels somewhat contradictory that there's an external scrutiny of the processes, which I think there is value in, but they don't have a scrutiny function. That's what we keep being told. So I think from a project perspective, yes, perhaps the role could be akin to a clerk of works role, but at arm's length, because again, my understanding is that NHS Assure don't involve themselves in the detail or any decision-making around a project. It's really more about asking the project team to bring forward information for their review. From an IPC perspective, I think I'm still unclear what the role is or how that's anticipated to benefit infection control teams at board level. Now, you may be hearing this for the first time, so we can take your answer in that context. But this is the sort of anecdotal response of an IPC nurse. What's your reaction to that? And is there anything that can be done to help people in Ms Guthrie's position understand what Assure's role is?
I think that that's quite interesting in as much as NHS Lothian have only undergone one KSAR, and it was a limited KSAR that was an engineering infrastructure KSAR. So I think that it is always incumbent to have an IPC person involved in that process. And I think actually one of our lead authors on the KSAR and involved in that process was one of our infection prevention control consultant nurses. So it's always important for us to have IPC involvement. We would hope that IPC understand through the high scribe process, which is part of the KSAR, that actually it is really important for IPC to be involved, and that our high are there to help support the boards to mitigate any IPC risks that come to light during the KSAR process. So we can't only have a technical solution to a healthcare build, we need to make sure that that dovetails with the clinical provision and that we take into account IPC practice.
One of the things that you refer to in your statement is an education programme.
Yes.
Is there anything in that which is going to help people in health boards understand Assure's role and where they fit into it?
So we've already had some senior leadership sessions for execs and board members around the role of NHS Assure, the assurance services. We have a number of sessions around lessons learnt to date, including lessons learnt from NDAP and KSAR. We also have some formal education that we have sponsored as well for IPC individuals. So the University of the Highland and Islands has an MSc healthcare module in the healthcare built environment, and NHS Scotland Assure sponsored 15 places on this module for health board staff, including IPC staff. High Scribe has been in place since 2007, and that also states the MD multidisciplinary team requirement for the healthcare build environment and the risks therein. So
Okay.
We also have, I know that there's also a national learning and development strategy, and I believe that the Chief Nursing Officer talked about his IPC framework, which will replace the framework that was brought in, I think, 2011. And that will have some role descriptors in it as well and refresh domains of practice. So I think that will also help.
So just in terms of the IPC involvement in these processes, there does appear to be some recognition that this is something that needs to be looked at and defined a bit more closely. Is that something that you would agree with from your perspective?
I think that a lot of these actual education opportunities have been in place for a number of years. The addition that we could bring to that is the sponsorship of perhaps the MSc module, which we have. We also provide HAI scribe training whenever we are requested. And I think the last time that we went to Lothian was in 2022, and we provided some training for them there as well. So we're always happy to do that on an ad hoc basis. Okay.
And just picking up what you say there about the MSc module at the University of the Highlands and Islands, is that something that's designed for IPC nurses or IPC doctors, or who's that designed for?
I think it's designed for anybody who has a role to play in the healthcare built environment.
And so far as you know, what's the content of the course?
I'm sorry, I don't know that.
Okay, all right. So Assure's involvement in relation to that is funding places on it, rather than helping drive the content of it or anything like that.
We may not have done that, but we are working very closely with NES around their healthcare build environment framework.
Okay, NES, that's
National Education Scotland.
Okay.
And they've just completed a learning needs analysis around the healthcare built environment.
Okay, and that sounds like it's perhaps a staging post on the way to rolling out a programme of training.
Yeah.
Okay. If we go back, please, to bundle 9 at page 73. Just to reorientate everybody about where we are, this is, remember we looked a while back at the letter from the Scottish Government announcing the formation of NHS Assure. If we just go back up to page 70 so that everybody can see which document I'm talking about. So that was the letter which announced NHS Assure. So page 73 is just part of an appendix to that letter, which is providing a bit more information about Assure. And just picking up under the heading of governance, it says that alongside building robust relationships across the system, NHS Scotland Assure and NHS boards will jointly sign off key stage assurance reviews at relevant stages of the project. What, in your view, does the sign-off mean? What does Assure's sign-off to the key stage assurance review mean?
So I would say that the sign-off means that we have a supported status for the movement forward of that build. And that may not mean that everything that we require in the KSAR workbooks, and I think that probably Thomas will take you through one of those in more detail this afternoon, is forthcoming, but that an action plan will be developed alongside the KSAR, which will allow risk mitigation that's been identified through that process. So, for instance, if we have a health board that have identified that they perhaps have not got, I don't know, an electrical certificate or something like that, they will make sure that that sits on their action plan and is actioned before they move on to the next stage KSAR.
Yes. Okay. The way that it was put in the target operating model, which was essentially setting the foundation for the development of Assure, we don't need to bring this up on screen, but the reference for anybody who needs it is bundle 9, page 19. And what it says is that the QHBE, which I think was an acronym standing for Quality in the Healthcare Built Environment, will work with NHS boards to deliver its services, ensuring transparency and ongoing reciprocal discussion of issues as they arise. Each report and remedial action plan will be jointly signed off by the QHBE and NHS board, with the QHBE being jointly liable along with the NHS board. And it's really that phrase, jointly liable, is the way that Assure has developed. Has it been slightly watered down from what was originally in mind?
I mean, bearing in mind I didn't join till September 2021, that has never been my interpretation of how NHS Scotland Assure would work.
Okay, so for as long as you've been involved, it's always been the idea that the sort of legal responsibility for the project will remain with the boards and the boards only.
Mm-hmm.
Yeah.
Right, I mean, at risk of just repeating what you've already said, Ms. Critchley, so since 2021,
Yes.
it has not been your understanding that Assure was jointly liable in any way.
No, that's correct.
Thank you.
Thank you.
And if we could just go back to page 73 of Bundle 9, just picking up from where we left off, the second paragraph under the heading Governance says that Healthcare Improvement Scotland will continue inspections of NHS hospitals and services through the Healthcare Environment Inspectorate, the HEI. NHS Scotland Assure will work with HIS to ensure inspections carried out by the HEI are supported by relevant expertise. Can you just expand on the sort of expertise that Assure contributes to that process?
I don't think that we do actually contribute to that process.
Okay. So that's perhaps something which was intended at the outset but is not done now?
Potentially.
Okay.
I can't comment.
I mean, are you familiar with the inspections that the HEI carry out to any extent?
Not particularly.
Okay. I mean, you may not know, and if you don't, please just say. But do you know whether their inspections cover the engineering systems in hospitals and their compliance with guidance?
I don't know whether they do or not.
Okay. And then just the next paragraph down, it says that NHS Scotland Assure will form a strategic partnership with National Education Scotland to deliver the Workforce Education Development Service, and will collaborate with PHS to share intelligence and expertise. Is that something that's underway?
Yes. So we are working with National Education Scotland around career frameworks for our healthcare built environment, to build a framework wherein we take engineers earlier on in their career and develop them with the skills that we would require across NHS Scotland as a whole. So we're not just looking at that as a recruitment for NHS Scotland Assure, we're looking at how we can do that to support all of the health boards.
Okay. And is that something which is still being developed, or is that in operation?
No, it's in its early stages at the moment, but we're working with NES around how we could do that and what the career framework and pathways might look like.
Okay.
We do have a model that we could base it on because we have that for our healthcare scientists.
And are you able to say at this stage, again, you may not if it's still at an early stage, but do you have any feel for when that idea might start to generate engineers with the right kind of expertise?
Not yet.
Not yet. Okay. If we go please to page 75 of Bundle 9. This was, I think, the letter you referred to earlier. It's DL 2023-03, again from the Health Finance Directorate of the Scottish Government. And this is the letter which says to health boards that all building projects going through a KSAR should not open to patients or the public until you receive a supported status from NHS Scotland Assure. Was that the letter that you were referring to earlier? Yeah. So I think it's the case that Assure doesn't have any formal enforcement or inspection powers. But would you agree that it does in practice have a power of veto over the opening of healthcare facilities?
I would say that yes, potentially it does. However, practically, this has encouraged the closer collaboration between NHS Scotland Assure and the health boards. So actually, we have become a supportive mechanism in ensuring that the health boards want to get this right first time.
Yes.
And it has been a positive move, I would say, particularly for those buildings that we have opened since this DL came into place.
Yeah, so I mean, one can see that everyone involved in this process wants to have a hospital which meets the requirements.
We do.
But would you agree that it's that sort of the potential of a veto, the potential of that power sitting in the background is what encourages the health boards to go along with what Assure are suggesting, if I can put it that way?
I don't think it does necessarily. So the relationships that we have built, both the KSAR teams and myself with the SROs for the majority of projects that have opened, have been really positive and fruitful. We are all wanting to provide the best quality care that we can for the public of Scotland. So actually, there isn't any difficulties around the suggestions that we might be making to support the health board to get it right.
Yes, so I think what you're describing is perhaps a more collaborative approach than my question might have suggested.
Yes.
Yeah.
Yeah.
Okay. But would you accept this much, that the KSAR process gives Assure a substantial degree of influence on the way that health boards proceed with their projects?
I think it is an encouragement to get it right first time. I think that as we move from a build that has the entire programme utilising the KSAR and NDAP process, that actually health boards will find this more and more easy.
Excuse me.
So as we look at a project from design phase right through to occupation, I think that we will solve problems earlier on and identify issues earlier on, which will lead to less and less derogations and remedial actions closer to commissioning and handover.
Okay, that's an interesting point. And does that work in two senses? So on a particular project, if the project is going through the KSAR process, would you anticipate that process will become more streamlined and easier as it goes on the basis that if you've confronted the problems earlier, there are fewer of them later?
Potentially, yes.
And does it also work in a broader sense that once a health board has been through the KSAR process for one project, it will perhaps have a clearer idea of what's required for future projects?
Yes.
And learn from the experience?
Yes. And we've had feedback exactly echoing that.
Okay. So is the expectation that the KSAR process is one which might be quite resource intensive at the early stages of its existence, but become a more streamlined thing in the future?
I think it will always be resource intensive, particularly around commissioning and handover, when you've actually got the shell of a building there that is ready to deliver services. One must always make sure that that is actually correct.
Okay. If we could go then to page 90 of Bundle 9, please. And this is the document I think everyone refers to as the tube map.
It is, yes.
Okay. And if we can just imagine ourselves starting our journey, I think the start point's up in the top left-hand corner, is that correct?
It is, yes.
And we see there a blue line which goes from the start, and it goes through strategic assessment, then initial agreement, outline business case, and full business case. And so do we see at each of the initial agreement, outline business case and full business case, there's a Scottish Government Capital Investment Group decision point.
That's right.
And also, we see there that at the initial agreement stage, there's a NHS Scotland design assessment process box. So that's an NDAP.
That's an NDAP, yes.
And then if we look at the outline business case and the full business case, we see that at those CIG decision points, we've got both a key stage assurance review and an NDAP. So are these, just in overview, are these the processes that are intended to provide the level of assurance that the CIG needs to allow the project to proceed on to the next stage?
Yes, they are. However, we are looking at an integration programme within NHS Assure. We are only in our infancy.
Yep.
We are still revising our governance frameworks and the requirement that we have for boards. So I'm not saying that that will remain exactly the same moving forward.
Okay. And then if we move from the blue line onto the sort of olive coloured line and then the green one, do we see there that in the construction phase, there's key stage assurance review, and it says there the number to be determined on a project by project basis. Is that something that still happens, or is there just one KSAR?
No, it's something that happens depending on what the build is and how large it is, and also how complex it is.
Okay. So can we take it that the more complicated or large scale the project, the more likely it will be that there's more than one KSAR?
There is the potential to be more than one, yes.
And how is the number of KSARs determined? Is that decided by the CIG, or is that done in consultation with the board? Or?
In consultation with the board.
Okay, and then if we just move on round to the green, we see that at the handover and commissioning stages, there's a key stage assurance review.
Mm-hmm.
And then after that, there's a box that says Project KSAR Lessons Learned.
Yeah.
Can you just explain to us a little bit about what that involves?
So lessons learned, we've done a programme of learning network events with presentations to the health boards and also sometimes their supply chain partners around what lessons we've learned from that process and how we can be reactive to the support that another board going through that process might require. If there are any themes that were particularly difficult, if there is any way that we can revise how we do that, and also if there are any recurring themes from build projects as well. So we're very keen to have lessons learned, even around the outline business case and full business case. We've done some lessons learned, learning networks. We've also done some key stage assurance review from the health board's perspective. So actually they've given us feedback around how it's felt for them and where we could have perhaps done things differently. So we're really keen. We know that we're in our infancy. We know that we may not stay in the format that we currently have, but we're very keen to do that in collaboration with our partners.
Okay.
Just so that I'm following this, in each project, irrespective of how many other KSARs there will be an identifiable stage in the process where the object is simply lessons learned.
Yes.
And that will be typically a meeting, or?
It could be a meeting, or it could be a number of meetings or a workshop. We will deliver that however the board wish to do it. They may wish to deliver to us their lessons learned, and we would deliver to them our lessons learned. And from that, we would make some improvements if they were necessary.
Thank you.
We've discussed the issue of accountability already this morning, but if I could just return to it briefly. Do you think it's likely that success in the KSARs will come to be seen as a kind of benchmark of compliance for projects?
I think so. We don't have anything else like the KSAR process in any of the other devolved nations. And we have had some very interesting discussions around that. In fact, last year I presented at the IHEAM conference around our governance process and the KSAR process. And I meet regularly with my counterparts from the devolved nations. So I think that there is something around, we are seen to be leading the way in this.
Yes, okay, so just a few things there. First of all, IHEAM, that's IHEEM, an acronym.
Yeah.
Do you happen to know what that stands for? No, I think it's something to do with healthcare engineering, but
It is,
we
yes.
can no doubt.
But I can't remember the exact words.
Okay. I think what you were saying is that you think this might be regarded as a model for other devolved nations to pick up on. Mm-hmm. And is your impression that they are interested in doing something like that?
It is. So we each talked about our governance structures and how we gained assurance in the healthcare build environment. And there was a large amount of interest in how we are doing that here and what that means for our healthcare build risks and the reduction and mitigation of risk.
Okay, it's very helpful to have that answer. When I asked about coming to view the KSARs as a benchmark of compliance, I wasn't so much thinking about how other people view it as how the health boards themselves view it. And I was wondering whether they will come to see the KSAR as the way in which they satisfy themselves that their hospital is compliant. Do you think that that's how they will come to view it?
Yes, and we have had some feedback to that effect as well.
Okay. Now, on major infrastructure projects, boards will typically engage both designers and technical consultants. And part of their function is likely to be ensuring compliance with applicable guidance. Mm-hmm. And the question is, how do you see that mix working? If you've got designers, technical consultants, and Assure all contributing to compliance with guidance, well, first of all, is there a risk that one is duplicating effort and expense?
I don't think so, because the KSAR process, the KSAR workbook process, just allows the health board and their supply chain partner to demonstrate their compliance and their achievement of standards and guidance. So it gives them an explicit way in which to document the processes that they've been through and thus show how they are mitigating any risks that might have arisen.
So you see Assure as doing something quite different from what the designers and the technical consultants are doing?
Yes. I think that they are looking at how operationally a building will function as well as the compliance around that.
Okay. I mean, and I never want to put words in a witness's mouth, but is one way to look at this that Assure is holding up a mirror to the designers and the technical consultants and the board so that they can reflect on what they're doing in relation to the compliance with guidance?
I suppose, yes. I suppose in a way it could be.
And is there another risk that perhaps arises that if Assure are effectively the gatekeepers to the opening of a hospital, that at least de facto, even if not in law, it will be Assure rather than the designers which is determining what constitutes a compliant facility?
I think that what we're doing is allowing them to give themselves assurance around whether or not they are compliant with any kind of guidance, building regulations, etc. I don't think that it is us stating that, it is them demonstrating.
I mean, is there any risk, as you see it, of blurring the lines of responsibility for compliance with guidance
No.
between designers and Assure?
No, I don't think that there is.
And why do you say that?
I think that it's very clear when we go through the key stage assurance reviews and the workbooks, the requirements that we have around documentation. So I think it is very clear what we're asking them to be able to demonstrate.
Okay. If you could go, please, to bundle 9, page 14. This is returning to the target operating model. And just really looking at the vision box. So again, this is obviously before Assure comes into existence, but the vision was, I've just lost my screen.
So have I.
There we go. What it says in the vision box is to be an internationally recognised national centre for reducing risks in the healthcare built environment. And it's really that vision of being internationally recognised. To what extent has that aspiration been achieved?
I think we touched on that in the last set of questioning around the fact that the devolved nations are quite interested in how and what we are doing. We are happy to work with the devolved nations around what their processes are, and we have been open and transparent about sharing what we are doing here.
Okay. And has there been any interest? I mean, I appreciate you're still in your infancy, but has there been any interest from beyond the devolved nations?
I don't know that there has been specific interests, but we are quite often asked to present at conferences. So I think that there is some interest in how we're approaching this.
Okay. And what would be, or do you see any particular benefits accruing to Assure or to the NHS in Scotland from any international recognition that's achieved? What would you see the benefits of that being?
I think the benefits would be around validation of the process for a new build, so that actually we are working in collaboration with the health board to produce a building that is fit for purpose and actually delivers safe clinical care. And I think that that would probably be the outcome that we would want replicated.
Yeah, I'm just trying to understand if whether there's a sort of, I mean, one can see that wanting to be internationally recognised is a sort of badge of approval, but I just wondered whether you saw any benefits deriving from that.
I think that the benefits are around the research that we're doing. So we have a research partnership with Edinburgh Napier University that we're looking to produce some more research around the healthcare build environment explicitly and exclusively. So I think that that will benefit the wider audience, not just NHS Scotland, England, Wales, Northern Ireland. It will probably benefit wider than that.
Okay. Now, if we stand back and ask ourselves why the need for assurance arises, would you agree that it's at least in part due to the fact that complying with the guidance is a difficult thing to achieve?
Yes.
And that there's a lot of it. You know, if one adds up all of the SHTM series alone, there's a lot there. And as guidance is by definition not prescriptive, and so judgment is needed when health boards come to apply it. In your view, and I appreciate that you're not a technical building person, but in your view, is there scope for simplifying the task of health boards by making some of the guidance more prescriptive or mandatory?
I think that it would be really difficult to cover or mandate for every potential scenario. So it is more simplistic for a new build. It is much more difficult for an existing build. I think from a technical perspective, it would be very difficult to write the guidance that covered every eventuality.
I mean, in the particular context of refurbishment, is the difficulty there that one is constrained by the existing building and the way that it was built, perhaps in the Victorian era.
Yes, in a very non-technical layperson,
Yeah.
I would agree with you, yes.
Yes, okay. So is there perhaps more scope for being prescriptive in the context of new builds than there would be in the context of refurbishment?
Potentially, but then you run the risk of having a two-tier guidance system, which I think may complicate things further.
Okay. One of the things that you cover in your statement is the standardization of rooms and repeatable rooms and standard designs and so on. If we could just go there, it's witness statement bundle 1, page 262. It's paragraph 81 of your statement. Yes, and you're talking here about, you say, repeatable rooms, standardised room configuration and standard designs that will meet requirements of the function of that space are being used to reduce design costs, embed quality and benefit patient care.
Yes.
Standardisation is one of the areas NHS Scotland Assure has engaged in from a research perspective and has developed repeatable rooms for use, linking in with national and international research.
Yes.
Can you just explain what's meant by the repeatable rooms and what you see as the benefits?
So a repeatable room is something that is a standard room in every hospital. So you may take a treatment room and actually the requirements for that room will probably be the same wherever it is situated in whichever hospital. And therefore you can standardise the room configuration and design so that it will meet the requirements and the function of that space. That actually reduces the need for a design. And if it's standardised, you will embed that standard and quality will be easier to replicate. So for instance, if you have a treatment room, you will say for this treatment room, it should be this size, it should have this type of equipment in it, and it will be utilised for the following clinical scenarios.
Okay. We have been supplied with a document about repeatable rooms. So if we could go to bundle 13, volume 10, page 159. And we can see there, just down from the bottom left-hand corner, that this is an HFS document from December 2020 and is just described as a draft. So this is preceding the existence of Assure. But is this a document that you're familiar with? Did you recognise it, or?
I have seen it before.
And to what extent does that represent the current position in relation to repeatable rooms, or have things moved on?
It doesn't, we've moved on.
It has moved on? From
there, yes. So we have 3 repeatable rooms or standardised room fit outs now, and we have another 7 in the pipeline.
Okay. Now, this document, at the time that this one existed, if we just go to page 161, for example, we see there the rooms that were covered at that point in time, which were, I suppose, what one might call reasonably straightforward rooms. So adult single bedrooms and en suites and a consultation room at the bottom. What's that expanded out into? Which other rooms are now available in a standardised format?
I'm sorry, I couldn't tell you.
Okay. Well, maybe Mr. Roger can help us this afternoon. Okay. And I think you said, did you say there were 10 rooms, I think?
We've got 3, which is the bedroom, ensuite, exam room, and then we have a further 7 in development.
A further 7 in development, yes. Okay. Now, one of the things that you mentioned in your statement, and I think you may have mentioned it again this morning, is the NDAP process, which that's something else that Assure runs together with the KSARs. Can you explain how the NDAP and the KSARs interrelate? And really, in particular, when it comes to the compliance of design with guidance for engineering systems?
So the NDAP has been in use since 2010. So, and it is looking at the design and practicality of a build. The NDAP process typically it ends at full business case because the design should be locked in by then. So KSAR will look at electrics, medical gases, ventilation, water, fire. NDAP is broader than that. It looks at the design process for a building. It will also look at the energy requirements, the amount of light that's let in, the usage of those rooms, and how that will link in. So it is a more of a design type of review than the KSAR. So I think that the NDAP process is managed by Property and Capital Planning team within NHS Scotland Ashore, and the KSAR is predominantly managed by engineering. So its NDAP process is also mandated and is part of the Scottish Capital Investment Manual process. So I think that we acknowledge that we are asking boards to complete an NDAP and a KSAR at certain points around the tube map, as we looked at earlier. As I said at that point, we are doing some internal integration processes, and that may not remain for the long-term future.
Okay, and is that in recognition of the fact that the NDAP, at least as traditionally envisaged, overlaps to quite a large degree with the content of the KSAR?
Some of it does, but some of it is very different, and we wouldn't want to lose what we capture with that, because it gives a differing view of the build requirements.
I mean, if we could go please to 2022 bundle of documents, bundle 8. Now, if we could maybe just go down, I don't unfortunately have a page number, but if we could go to the inventory. Yes, if we can go please to page 63 of that bundle. So this is the Scottish Capital Investment Manual supporting guidance, design assessment in the business case process. We can see down at the bottom it's from July 2011. Mm-hmm. Now, is this a document that you're familiar with? I don't want to...
It has been superseded in 2017.
It's been superseded, okay.
Or updated in 2017.
All right.
Is my understanding.
Well, it may be that this particular question has been superseded by the 2017 guidance, but if we could go please to page 65, we see there a heading, Compliance with Healthcare Design Guidance. And it refers to the policy on design quality for NHS Scotland, and that was introduced in 2010. And it says the SGHD, so Scottish Government Healthcare Directorate, must provide guidance on compliance with those aspects of statutory and mandatory requirements which are particular to the procurement, design and delivery of healthcare buildings, and guidance on best practice. This will be effected through the support to be provided by Health Facilities Scotland and others. And then it goes on to say that accordingly, projects submitted to the Capital Investment Group for business case approval will be assessed for compliance with current published guidance. To facilitate this, boards will be requested to submit a comprehensive list of the guidance that they consider to be applicable to the development under consideration, see inset on next page, together with a schedule of derogations that are required for reasons specific to the project's particular circumstances. Now, if we go over the page, we see a list of the kind of guidance that we're talking about. So it includes the SHTMs. And then just in the text underneath the box, it says that the NDAP will then make an assessment of the design information available at each business case stage for compliance with the guidance. Now, it may be that this is in this respect, that the 2017 guidance supersedes this, but my question was simply, to the extent that the NDAP covers compliance with SHTMs and so on, is the view that that's now been superseded by the KSAR process?
I don't think that it is. I think that there are some similarities between the NDAP and the KSAR process, and there may be a bit of duplication. However, that isn't everything that the NDAP does.
No, I appreciate that. It's just, I'm really just focused on the question of compliance with SHTM guidance, whether that's something that now leaves the NDAP and is dealt with by the KSAR.
I think it's probably dealt with by both.
By both?
Currently.
Yeah, okay. But I think you said that there's a review underway to look at all of this, and is streamlining it in the event of overlaps one of the things that you will be addressing?
Yes, it is.
I know at the time, my lord, I still have a few minutes worth of questions for Ms. Critchley, so that may be an appropriate time to stop, if convenient.
Well, I'll be guided by you, Ms. McClellan. Seem a convenient moment to take a coffee break. If you could be ready again to resume at 10 to 12. Thank you, Ms. Critchley.
Thank you. Please.
Mr. McLeod.
Thank you, my lord. Ms Critchley, we talked earlier about the range of services that NHS Scotland Assure provides to health boards. Are any of those services for which the health boards have to pay Assure, or are they all just provided in the course of the NHS's work?
They're all provided in the course of NHS's work.
So there's no, for example, the advice, if a health board calls up for advice,
We don't charge them.
there's no charge. Okay. And there was a reference, I think, in your statement to the provision of authorising engineer services. Again, is that something which is just provided, or is that charged for?
It is. It's just provided.
It's just provided. Okay.
Sorry, what was that?
Authorising engineers would just provide that service.
And you provide that well,
Yes,
you don't make a charge.
we don't.
Thank you.
And another topic that you touch upon in your statement, I think, is what happens if, through the KSAR process or perhaps otherwise, a conflict arises or a disagreement arises between the views of the Assure engineer on the KSAR team and the design engineer engaged by the health board, perhaps. How are those sorts of disagreements resolved?
So we have an escalation process, although I must state that we have never had to use it. So in the first instance, if we have a disagreement on something that's in a KSAR report, then that would be referred to the KSAR team to have that discussion first. If that didn't resolve the issue, then it would potentially go to our head engineer, Thomas, who you will see this afternoon. If that then didn't resolve, it would go up to the Assistant Director of Engineering and Assurance. If that didn't resolve, it would come to myself, and then if that didn't resolve, it would potentially escalate to our Chief Exec, Mary Morgan. However, as I've stated, we have not had to use that escalation process.
Okay. If the disagreement, I appreciate this is a hypothetical question, but if the disagreement concerns something like the SHTM guidance, something for which Assure is responsible, something which Assure itself publishes, would Assure regard itself as the gatekeeper of what that guidance means?
I think it depends on the circumstance. So that could be quite different in different circumstances. However, I think that we understand that the extant guidance isn't always totally up to date because of the cycle of updating. So most of our SHTMs come from HTMs from NHS England. Their cycle is round about every 5 years. We know that sometimes research will supersede that. If we feel that that is appropriate, then we'll have that discussion with the health board.
Okay, so I think you're describing there a sort of open-minded attitude. If a question comes up about the guidance, you're sort of potentially at least open to persuasion of the view taken by a design engineer. But if there's a situation where Assure sticks to its guns and thinks that the design engineer is wrong,
Yes.
Does that then come down to what we were describing earlier as the sort of practical power of veto, that ultimately Assure would be able to say, well, we think that your interpretation is wrong and we're not prepared to support the project if you continue on that basis?
In that instance, if necessary, we would escalate to SG as well.
To the Scottish Government?
Yes, and they would become involved in the discussion.
But ultimately, the KSAR process is there to support the decision-making of the Capital Investment Group. So in that sort of situation, if there was a genuine dispute over a technical issue like that, rather than Assure simply determine the matter by saying we don't support the project, you're saying that you would be able to lay that information in the open to the CIG and let them decide how they wanted to proceed?
Potentially, yes.
Yeah, okay.
Although, as I state, we haven't had
You
to
haven't
use any
that-
escalation
yes, that-
processes.
That hypothetical bridge
Yes.
hasn't yet been crossed.
No.
Yep. And you say in your statement that no project has yet gone the full way around the tube map through all of the KS ARs, but that nonetheless lessons are being learned on an ongoing basis. So I take it from that the KSAR process is one which is likely to evolve as time moves on.
Yes, I think so. I mean, we are in our infancy. We're only 2 years old. We've done an awful lot of looking at the governance processes that we have in place. We work very collaboratively with the health boards. We understand that actually we may evolve from where we are now. We work also very closely with Scottish Government. They are very content with our direction of travel, and obviously we would discuss anything with them as well.
Okay. And are there any particularly big lessons that have been learned from the KSARs so far that have had an impact on the way that they're carried out?
I think that there is something about how much information we may require or could potentially be submitted as part of one of the KSAR workbooks. If we're looking at a very large scale build project, then that can be many thousands of pages of documentation. I think what we have learned is that we will not wait to publish a report before we find any issues. So if we're looking through a KSAR workbook and we're coming to the conclusion that there is an issue that has not been risk mitigated, then we would contact the board directly. So we wouldn't wait until we'd done the whole of the workbook before getting back to the board. And I think that speaks to the collaboration and the relationship that the KSAR team will have with the board.
Okay. So are you by that process intending to give the board the earliest possible notice
Yes.
that there's an issue that might need to be addressed?
Yes.
And in terms of the volume of documentation, as you say in your statement, you say that some of the complicated projects can lead to thousands of documents
They can.
being provided to Assure. Is that something that you've been able to streamline, or again, is that something where it's just on the radar screen as something to be looked at?
I think for some of the projects, it's absolutely necessary that we see that level of detail and documentation. I think that as we work our way through the processes, as I said, we haven't gone all the way around the tube map. It may be something that we actually look to address, but currently we're thinking that actually it is appropriate.
Okay. And does Assure recognise that there may be, on any building project, time pressure or commercial pressure to move things on?
Yes.
Whereas Assure perhaps has the luxury of being free from those pressures. And does Assure take steps to make sure that it's fitting in with the sort of timescales that affect health boards and their project?
Yeah, we are endeavouring to do that. And as I stated earlier, once we start to go through a project right from the start, we're hoping that as we pick up risks and mitigate those earlier on, then actually that slows the amount of derogations or anything that might need to be done at the commissioning and handover stage.
Okay.
So whilst it might take a little bit more time earlier on, it should save time later in the process.
Okay. We touched earlier upon the topic of involvement in the KSAR process by infection prevention and control staff. And the inquiry has heard evidence from IPC team members at NHS Lothian. And I take what you said earlier, that NHS Lothian, I think, has only been through one KSAR, and it was restricted to a particular topic, I think.
Yeah, electrical infrastructure, I think it was.
Okay, but the witnesses from NHSL have expressed concerns about the extent to which the burden of compliance with built environment guidance is falling on them, the IPC teams. If we could go please to bundle 13, volume 7 at page 332. Page 332, please. Now, there's no reason to think that you will have seen this email before, Ms. Critchley. It's an email which is passing around within NHS Lothian, and it's in the context of the Assure Key Stage Review that NHS Lothian was undergoing. And I'm just going to read from it. I'm going to ask you some questions about it. So it's from Lindsay Guthrie, who's the lead IPC nurse at NHS Lothian. And she says, hi all, can I ask if the attached NHS Assure tool has been shared with others at an exec board level, please? The Assure process or KSAR tools have not been discussed or shared with the IPC managers network nationally, but is now live. Is a gap analysis planned to identify any weaknesses in capacity, system or process, or governance as outlined in the attachment? I have to highlight my significant concerns re the NHS Assure expectation about the level of IPCT involvement in projects following a discussion between Assure and my HAI lead nurses, and make you aware that we do not have the capacity in the short or medium term to provide this. There is a policy national ask here which has not been informed by any IPC workforce or capacity scoping exercise, and is in direct conflict with the wider workforce issues already identified in the Scottish Government IPC National Workforce Review. I'm not aware of any plans nationally for additional investment in IPC capacity, but even if funding is available, there is simply not a pool of suitably qualified and experienced IPC nurses or doctors to provide the required expertise. Now, could I just ask in general terms, what's your reaction to what you see here, which is the reaction of an IPC nurse in a health board to what's being expected of her in a KSAR context?
That isn't something that's echoed through the other health boards. So I don't think that we have had that level of pushback from anybody else. I think that the skills that we're asking for are those that are in HAI Scribe, which has been in place since 2007. And also there was the 2011 piece of work, which is now being repeated by the Chief Nursing Officer Directorate around healthcare build knowledge and skills and the role descriptors. So I think that whilst I do understand what she's saying, I don't think that, as we've discussed earlier, that actually the IPC capacity has diminished in the boards because we've had a circular move of staff around. And I would be very, very surprised if we hadn't gone through the IPC networks around the KSAR process.
Sorry to interrupt you, but no? was that something that happened prior to your arrival at Assure?
Yes.
Yeah. Okay.
But also there is a section in the National Infection Prevention Control Manual which has been developed for IPC teams to support them through the KSAR process.
And do you know when that came online?
No, I don't know the exact date, I'm afraid.
Okay, I mean, might it have become available subsequent to that email, which is, that email is from March 2022?
I don't know.
Don't know, okay. I mean, from your perspective in Assure, do you see the KSAR process as one which is adding to the burden of IPC teams in health boards?
I don't think that it is, because they've always been ascribed to be part of the process of a healthcare build. So from 2007, when HAI Scribe came in, there has always been a role for them. I don't think that the ask is much more onerous than it ever has been.
Okay, so if the perception of IPC teams in health boards is that the KSAR process is massively increasing the burden on them, is that likely to reflect a misunderstanding of what's expected of them?
I don't know, because I haven't had feedback like that. So I would just be guessing if I responded.
I mean, I am right in thinking that let's take the example of a new build, there are the requirements, strictly speaking, not specific to the infection and prevention control team, but there are requirements on the health board to go through the HScribe process.
Yes.
And that will involve pieces of work at specific times. And the KSAR process will involve maybe similar sorts of work, but at different times and additional pieces of work. I mean, I've got that correct?
I think so, but there would also be the submission of some of the high scribe documentation as part of the KSAR.
Yes, but the process is, the KSAR process is additional.
It is.
And I can see that work done in one process might inform work in the other process, but it's not just the same bits of work.
It's not entirely the same.
No. Thank you.
You said that you hadn't had feedback from IPC nurses about the KSAR process. Is this an area where there's scope, perhaps, for dialogue with IPC representatives to make sure that they're correctly understanding what's expected of them through the KSAR process?
Yeah. And, you know, we are happy to support that process from an RHI perspective, and we do take part in the IPC networks. We do provide training opportunities and learning networks around IPC in the healthcare built environment. And as I've said, you know, we are happy to sponsor training opportunities as well.
Okay. And would you see that as a route through which there might be possible further refinement of the KSAR process to make sure that the demands placed on IPC teams are demands that they're sufficiently resourced to meet?
We're always happy to have a look at the processes that we've got in place to make sure that they are as efficient and effective as possible.
Yeah, okay.
And RHI are part of our internal integration programme.
Okay. One of the themes that comes through from the evidence from the IPC people is that they don't want to be seen as building control officers, but they feel that that's the nature of the burden that's coming on them, and what they want to do is to confine their input to things that fall within the recognised scope of their professional qualifications. And I would assume that Assure would want to proceed in that way too.
Yes, and you know, I think that the work that the CNO is doing to replace the 2011 programme will help to support that process too. I would say that HAI Scribe actually clearly articulates that it is not just IPC nurses who need to be involved in that process, as does the KSAR process.
Yep.
We would not wish for them to do anything out with of their competency.
Yep. Could I ask you a question about knowledge transfer? The inquiry has heard evidence, again from NHS Lothian's IPC team, that when concerns about water and ventilation systems at the Queen Elizabeth Hospital in Glasgow were emerging from around March 2018 to July 2019, right, this will be before your time,
Yes.
But this is the period that we're talking about. What they say is that there was a lack of proactive information provision from HFS and HPS to IPC teams in NHS Lothian. And the question is simply, does Assure have arrangements in place to keep health boards informed as and when IPC risks start to emerge elsewhere within the NHS?
We do, and we would use the lessons learned process for that. However, my understanding is in this particular case that the medical director from Glasgow was going to feed back directly to the medical director from Lothian and asked our staff not to do so. And that is minuted in a meeting.
Okay. And just moving from that specific issue to the general one can imagine that IPC risks may start to, or IPC concerns may start to emerge in a particular part of the NHS, but it may not always be clear what the cause is or what the source is, perhaps even what the solution is. How is something like that handled within Assure, where there's that sort of growing issue, perhaps an element of uncertainty associated with it, but there may be a need to let other health boards know what's going on? How is that dealt with?
So we have a process by which we, that's described in the National Infection Prevention Control Manual, which describes how a health board should report an infection. We would look at that. We would then look at if there were any other infections in the same health board that were caused by the same organism. And then we would have a dissemination process by which we would be able to discuss that. That potentially may go through the infection prevention control networks. I think that we would also do some research into that. So we would look at whether or not there is any literature reviews that we may be able to do. And then we would hope to share that information wider.
And is there an existing, established and recognised process for doing that, which is followed when that sort of information emerges? Or are you just simply saying how you would expect to react when that sort of information came in?
I think that there is an existing process through which that will happen.
Okay. Now, paragraph 126 of your statement, which is witness statement bundle 1, I think page 277, maybe 276. Yeah, paragraph 126. So you say there that Assure, Scottish Government and the health boards now have governance systems and processes that significantly mitigate healthcare build risks. Mm-hmm. In relation to the RHCYP DCN, I consider it would be likely that such significant issues as did emerge could be identified through the governance processes that NHS Scotland, Assure and health boards now have in place. Could I just ask, why do you say that?
I think that because we now have the tube map with the KSAR and the NDAP process, that we would have a number of points within a healthcare build programme at which we would seek to identify any risks and any non-compliance with guidance. And whilst I cannot say categorically that that wouldn't happen again, I think that we would have the opportunity to identify risks now in perhaps a way that we didn't before.
I mean, to what extent are you familiar with the particular details of the way the issue occurred at the RHCYP in relation to the critical care ventilation?
I have no real in-depth knowledge of that at all.
Yeah, okay. I mean, just at a very high level, on one view of the evidence at least, the health board engaged a designer which produced a design which the designer believed and still maintains was compliant with the guidance. The contractors told the health board that the design was compliant with the guidance, and the ventilation system as built had been supported by a clinical risk assessment which supported some of its parameters. Given all of these elements, do you still think that the KSARs would have picked up the non-compliance issue?
I don't know. However, if we had a situation similar to that now, the KSAR workbook documentation would allow us to seek assurance around some of those things.
Okay, so in responding to the workbook questions, do you mean that documentation would be produced and at the very least that would present an opportunity for
Yes.
a second pair of engineering eyes to look over what was going on?
Yes.
Yeah, okay, and I take what you said, that you can't be categorical that it would have picked it up. Now, if we look to the future, one of the things that's arisen is what's sometimes described as a more challenging fiscal environment. And so there's perhaps a reduced prospect of new build hospitals and more likelihood for refurbishments and maintenance instead.
Yes.
Do you see that as affecting the way that Assure does its work? And if so, in what way?
I think that it will mean that we have less new builds, but I don't think that it will mean that we have less work. I think what it means is that we will need to pivot and look at refurbishment opportunities and realignment of service delivery, perhaps in a different environment. And I don't think that the requirement for my staff skills will be reduced by that at all.
We mentioned earlier that it can be more difficult to comply with guidance in the context of a refurbishment. Do you anticipate, therefore, that there might be more pressure on this question of compliance and a need for greater judgment about whether design solutions are appropriate or not?
I think that that is a possibility. I think that we will have to be very clear when we're looking at refurbishments in the future around the clinical strategy linking in with how we're going to deliver services and where we're going to deliver them. And yes, I do think that there may be a requirement for more collaboration around the solutions that might be required.
And then finally, on the question of recruitment, we touched upon this earlier, and you explained that there were processes underway to deal with the way the workforce does its work, which in some way is going to free up resource, I think was the broad effect of it. Do you feel that Assure has enough engineers and enough infection control people to do what's expected of it, or are there still pressures which are going to have to be confronted?
I would say that we've gone from an organisation with a very small number of engineers to an organisation with 16 to 18 engineers now. We are able to probably consume our own smoke at the moment with the work that we have on hand.
Can you just, I've never heard that phrase before. What does that mean?
Sorry, that's a Lancashire colloquialism. I'm really sorry.
No, we're open to education.
It means that we are able to cope with the work that is coming in that we know about. So the remaining builds and the KSARs that we've got on the books at the moment, we're probably able to think about being able to do that ourselves. However, we will need to monitor very closely our work plans and the work that will be coming in because of the pivot to refurbishment and delivering services in a different way.
Yes. Okay. Thank you very much, Ms. Critchley, for asking my questions. It may be that others have some questions, so please stay where you are for the time being.
Ms. Critchley, just really a small point, picking up on your answer about provision of authorised engineers. Now, as I understand it, the authorised engineer is a term of art used in, for example, SHTM 0401. And the effect of the technical memorandum is to impose certain obligations on health authorities to instruct authorised engineers to do certain things. Now, as I understand it, at present, a health board would usually go to the private sector for that. They may have their favoured consultant, and it may depend on the availability of that consultant. But do I understand from your answer that if a health board wished, they could apply to Assure, say, we require an authorised engineer to do this, and you would simply respond to that?
Currently we would. However, we do not have the capacity to respond to every board. So currently some boards employ their own authorising engineers. We were providing that service as a supportive mechanism, as a proof of concept, to see whether that worked or not. But if we were going to provide that holistically across the whole of NHS Scotland, we wouldn't be able to do that without an additional resource.
Right. Thank you. Now, as Ms McLennan indicated, there may be questions which the legal representatives would wish him to add to the questions he's already directed to you. And our practice is to allow about 10 minutes or so for discussion of that. So could I ask you to return to the witness room in the expectation of coming back in 10 or 15 minutes to confirm what the position is? Carol, could I ask you?
Thank you.
Please stand.
Please stand.
Mr. McLennan?
Thank you, my Lord. There is one question which I have been asked to raise, or a line of questioning which I've been asked to raise, which I'm content to deal with, although given the scope of it, I think I should perhaps run it past your Lordship first.
Right.
It arises in the context of this hearing, of course, being concerned with the Edinburgh Hospital. And you may recall at the tail end of my examination of Ms. Critchley, there was a reference to communication to health boards about issues arising in other health boards. And in that context, Ms. Critchley referred to a minute recording a request by Greater Glasgow and Clyde Health Board that communications about the issues arising there were carried forward directly with NHS Lothian and not through, I think it must have been HFS at the time. And so I've been asked to ask some questions arising out of that, essentially whether that was a request which caused concern to HFS, what reason or reasons were given for it, when the meeting was, and who was at it. Now, since that does concern the communication of information to NHS Lothian, I've taken the view that it does fall within the scope of this hearing, but I am, of course, conscious that the Glasgow Hospital is going to be the subject of other hearings by other council. But I think that matter should be capable of being the subject of fairly circumscribed questions.
Remind me if that information actually was provided by the witness when this happened.
I can't remember the precise detail of it, but I was putting to her evidence which had come from, I think, Lindsay Guthrie about the information received by NHS Lothian in relation to events as they were emerging at Glasgow. And it was in that context that Ms. Critchley referred to a decision, a minuted decision, that communications should be direct between the health boards rather than relayed through, as I say, I think it must have been HFS at the time, or perhaps HPS.
It would seem to be sometime before 2021.
Yes, indeed. But from her answer, Ms. Critchley's plainly aware of a minute recording this, and it was...
I can see that one might take longer in considering whether to ask the question than actually asking the question or the line. Right, I'm content to go ahead, but apart from anything else, this does not seem to be the best witness to deal with this matter. But I mean, if all she can say is she saw a minute.
Yes.
However, let's open the line with caution.
Indeed, my lord.
Ms. Critchley, there is one matter which Ms. McLennan will explore with you.
Okay.
Ms. McLennan.
Thank you, my lord. And I have to be fairly careful about this, Ms. Critchley, because the subject matter of this hearing is the Edinburgh Hospital and not the Glasgow one. But in the context of your answers earlier on, one of the questions I had asked you was about information transfer,
Yes.
where an infection control issue arises in one health board, how that information gets to another health board. And the question was particularly directed about how NHS Scotland Assure now handles that sort of thing. And in that context, however, you referred to a matter which must, I assume, have arisen at an earlier stage, and it concerned the transmission of information from Greater Glasgow and Clyde Health Board in relation to the Queen Elizabeth Hospital to NHS Lothian in relation to the RHCYP. Mm-hmm. And in that context, you referred to a minuted request or decision that communication be direct by Greater Glasgow and Clyde Health Board to NHS Lothian rather than mediated through, and I'm not sure which organisation it would have been, but perhaps HFS or HPS.
Yes.
Is that a fair summary of what you had said earlier?
Yes, but that is the full extent of my knowledge.
Okay, now you referred to a minute of that. Was this something that happened before you arrived?
It was.
With Assure?
Yes.
But is this a minute that you've seen?
No, I've heard anecdotal evidence that there was a minute stipulating that.
Okay, and apart from what you've said about that so far and the anecdotal information about the minute, do you know any more about the matter than that?
I'm afraid I don't know.
Okay, well, I can leave it there. So thank you very much, Ms. Critchley.
Right, well, I would propose to accept Ms. McLennan's analysis of that. Now, does anything arise that any legal representative wishes to raise? No, I'm taking silence as no. Ms. Critchley, thank you very much for your evidence. You're now free to go, but you go with the thanks of the inquiry, not only for your attendance, but for the preparatory work that attendance will involve. I mean, I appreciate it will have been significant, but thank you very much, and you're free to go.
Thank you, Lord Lobby. Thank you. It was fun.
Now, my understanding of the position is that we will hear next from Mr. Roger, but he was scheduled to arrive at 2, and that's when I intend to take his evidence. So we'll rise just a little earlier than we might otherwise have done, and we'll sit again at 2 o'clock. Thank you.
Stand.